Welcome. I hope you're enjoying the day. We're going to be reviewing the 2018 AHA, American Heart Association, and ACC, American College of Cardiologists, along with several other organizations, guideline on the management of blood cholesterol. These are the objectives for this tutorial on hyperlipidemia management. Lipids are a structurally diverse group of organic compounds that are insoluble in water, but soluble in alcohol, chloroform, ether, and other solvents. Some lipids are stored in the body and serve as an energy reserve, but are elevated in various diseases such as atherosclerosis. Cholesterol and triglycerides are the two main lipids in the blood. The body uses cholesterol, an essential component of all cell membranes, to form steroid hormones and bile acids. The liver produces most of the body's cholesterol, but an estimated 20 to 40% comes from food sources. Triglycerides are important in transferring energy from food into cells. As an independent factor, elevated triglycerides are associated with an increased risk of coronary heart disease. Likewise, the risk of coronary heart disease increases as blood cholesterol levels increase. Cholesterol and triglycerides circulate in the blood in a combination with protein-bound phospholipids. This complex is called a lipoprotein. There are four basic groups of lipoprotein. A brief description of each is listed on the slide. We don't really pay much attention to the chylomicrons. The VLDLs and the LDLs are basically the bad guys. Remember, L is lousy. The HDL is the good guys. H stands for happy or healthy. High concentrations of HDL seem to protect against the development of coronary heart disease. Experts believe that cholesterol in HDL, in contrast to that of LDL, does not become incorporated into the fatty plaques that develop in the lining of the artery wall. Therefore, the level of total cholesterol is not as important as the distribution of the cholesterol in the levels of LDL and HDL. The comparison levels of LDL and HDL is expressed as a ratio. The optimum LDL-HDL ratio is below 3:1. The ratio may also be expressed by whole numbers rather than an actual ratio. For example, the optimum ratio of LDL to HDL is below 3. Even though the LDL to HDL ratio is more accurate, the ratio of total cholesterol to HDL is more often used to predict the risk. The ratio is obtained from dividing the total cholesterol by the HDL level. For example, if a person has a total cholesterol of 200 milligrams per deciliter and an HDL cholesterol of 50 milligrams per deciliter, the ratio would be stated as 4:1 or 4. The goal is to keep the ratio below 5:1. The optimum ratio is below 3.5:1. This is not the same as the LDL ratio, but is done more frequently because obtaining the total cholesterol is easier and cheaper. That is the way they are reported on our lab reports. In patients with no evidence of arteriosclerotic cardiovascular disease, assess risk factors, including lipids, every 4 to 6 years. Some people, such as people who have had heart disease or diabetes or have a family history of high cholesterol need to get their cholesterol checked more often. Children and adolescents should have their cholesterol checked at least once between ages of 9 and 11, and again between ages 17 and 21. According to the AHA-ACA 2018 guidelines, no numeric goals for lipid levels are given. Based on intensity of statin, there is an LDL reduction goal of 30 to 50% or 50%. The rationale for this is that clinical trials did not show a decrease in morbidity and mortality at certain LDL levels. The National Lipid Association does have goals. I put these goals in here because you need to know what the optimal levels are, and I've highlighted them. Based on extensive review of the evidence, the expert panel identified 4 groups that would benefit from statin therapy. The first group are individuals with clinical ASCVD risk. There's high risk and very high risk, and we'll look at that in a couple of slides. Then there are individuals where the LDL is greater than 190. Then there are individuals with diabetes who are 40 to 75 years old with an LDL between 70 and 189 and without clinical ASCVD. And the final group are individuals without clinical ASCVD or diabetes with an LDL between 70 and 189 and an estimated ASCVD risk of greater than 7.5%. Now, ASCVD is defined as acute coronary syndromes, history of myocardial infarction, stable angina, coronary or other arterial revascularization, stroke, TIA, or peripheral artery disease. A healthy lifestyle reduces arteriosclerotic cardiovascular disease risk at all ages. In younger individuals, healthy lifestyle can reduce development of risk factors and is the foundation of ASCVD risk reduction. In all age groups, lifestyle therapy is the primary intervention for metabolic syndrome. This is a rather simplistic plan for lifestyle changes. The National Lipid Association has multiple handouts for patients with specific directions. They also have an app. I put the website of the patient teaching materials in the lower right-hand corner of the slide. Who should be treated with a statin? The addition of a non-statin has not been proven to further reduce cardiovascular risk. Therefore, non-statins are no longer routinely recommended except in very specific situations. We will talk about each one of these groups. You are going to need to know this table. The first group. Very high risk includes a history of multiple major ASCVD events or one major ASCVD event and multiple high-risk conditions. These lists are on the next slide. In very high-risk ASCVD patients, it is reasonable to add ezetimibe to maximally tolerated statin therapy when the LDL level remains greater than or equal to 70. In patients at very high risk whose LDL level remains greater than 70 on maximally tolerated statin and ezetimibe therapy, adding a PCSK9 inhibitor is reasonable. Although the long-term safety, greater than 3 years, is uncertain and cost effectiveness is low, very high risk includes a history of multiple major ASCVD events or one major ASCVD event and multiple high-risk conditions. This is the list. So the major ASCVD events include recent coronary syndrome within the past 12 months, history of MI, and that's in addition to the previous recent coronary event, history of ischemic stroke, and symptomatic peripheral artery disease. High-risk conditions are generally age, greater than 65 years of age, having a history of family hypercholesterolemia, history of prior coronary artery bypass or percutaneous coronary intervention outside of the major ASCVD events, diabetes, hypertension, chronic kidney disease, current smoking, persistent elevated LDL despite maximally tolerated statin therapy and ezetimibe, and a history of congestive heart failure. In patients with severe primary hypercholesterolemia with an LDL level greater than 190, begin a high-intensity statin without calculating the 10-year ASCVD risk. We will talk about the calculation of that ASCVD risk later. If the LDL level remains greater than 100, adding ezetimibe is reasonable. If the LDL level on a statin plus ezetimibe remains greater than 100, and the patient has multiple factors that increase subsequent risk of ASCVD events, a PCSK9 inhibitor may be considered. Again, the long-term safety of greater than 3 years is uncertain and economic value is low. In patients 40 to 75 years of age with diabetes and an LDL greater than 70, start moderate intensity statin therapy without calculating the 10-year ASCVD risk. In patients with diabetes at higher risk, especially those with multiple risk factors, or those 50 to 75 years of age, it is reasonable to use a high-intensity statin to reduce the LDL level by greater than 50%. The ASCVD Risk Estimator Plus can be used to estimate the 10-year ASCVD risk. It uses the pooled cohort equation. It's available at the website listed there on the left-hand side. The web address provided is for the online version. There is an app available in the different app stores for the different phones. As you can see, there are different parameters that you need to plug into the equation to calculate the risk. The gender, age, race, total cholesterol, HDL, LDL, systolic and diastolic blood pressures, whether or not the patient is on any anti-hypertension medications, any history of diabetes, or being a smoker. What I usually do is I have this calculator on my phone. I figure out the calculation and then write that on the lab sheet or in my notes. In adults 40 to 75 years of age without ASCVD and without diabetes and with an LDL level of 70 to 189 and with a 10-year ASCVD risk of greater than 7.5%, starting moderate intensity statin if a discussion of treatment options with the patient favors statin therapy. In addition, risk-enhancing factors favor statin therapy, and these risk-enhancing factors are listed on the slide. One thing I don't have on here is that if the risk status is uncertain, you can consider using coronary artery calcium to improve specificity. And I've never done that before, so you won't be tested on. This is a group of criteria that you can use to rationalize your choice to put your patient on a statin and he or she does not fit into one of the other 4 groups. This is using your clinical judgment on whether or not a patient needs to be on a statin. The most common adverse reaction from statins is muscle complaints. About 30% of the patients will complain about muscle symptoms. The patients may complain of pain, tenderness, stiffness, cramps, weakness, or fatigue. The symptoms are usually in large muscle groups, which are affected symmetrically. Symptoms usually appear early after starting the statin, but can be later on. There are multiple terms listed here that are used to describe statin muscle symptoms, but the most serious of all of those is the rhabdomyolysis, but it occurs in less than 1%, 0.06% of the patients. Statins are metabolized through the CYP3A4 pathway in the liver. Some of the metabolites are excreted through the kidneys. Many of the risk factors for muscle symptoms are competing for liver metabolism, such as polypharmacology, use of medications or foods that increase statin levels, or alcohol or drug abuse. In addition, people over 75 to 80 years of age often have declining liver function. Some muscle symptoms can be prevented, so do not use gemfibrozil with a statin. Screen for drug interactions, adjust dose or use a different statin accordingly. Ensure dose is appropriate for renal function. Ensure the statin dose is appropriate based on cardiovascular risk. Consider a moderate intensity statin instead of a high intensity statin for patients with risk factors for statin muscle symptoms. Avoid simvastatin 80 milligrams daily. This is just a chart you can use as a reference to choose the specific statin and its dose that is recommended to be used as high, moderate, or low intensity. Again, this chart you must know, and this is one particular time where you need to know the dosages. This is a combination of the previous tables. It lists the high-intensity statins and the patient subgroups for which the benefit of statins outweighs the risks. Note that secondary prevention has a different meaning than what nursing and public health uses. In the context of this, secondary prevention means preventing additional attacks of cardiovascular disease after the first attack has occurred. Likewise, this is a combination of the previous tables. It lists the moderate intensity statins and the patient subgroups for which the benefit of statins outweigh the risks. Again, the secondary prevention has a different meaning. Finally, this is the third combination of the previous tables. It lists the low-intensity statins and the patient subgroups for which the benefit outweighs the risks. Low-intensity statins are usually only used for patients who cannot tolerate higher doses.
So this low ones, you probably don't need to know as much as the medium and highs. So if you're going to focus on medium and highs.
The route of elimination varies among statins, impacting the potential for drug interactions. Simvastatin, lovastatin, and atorvastatin are mainly eliminated via cytochrome P450 3A4 metabolism and are susceptible to those CYP3A4 mediated drug interactions. Pravastatin, rosuvastatin, and pitavastatin are not substantially metabolized by the CYP system and are more likely to be involved in transporter-mediated drug interactions. Fluvastatin is unique among statins because it is metabolized mainly by CYP2C9. It is not affected by CYP3A4 inhibitors. Most likely to interact with atorvastatin, lovastatin, and simvastatin, or these are the CYP3A4 metabolism drugs, will increase the risk of myopathy and rhabdomyolysis. So an alternative statin should be considered, such as fluvastatin, pravastatin, pitavastatin, or rosuvastatin, and they're generally less likely to interact. Most likely to interact with these atorvastatin, lovastatin, and simvastatin, again the CYP3A4 metabolizers, to reduce statin levels if concurrent use can't be avoided, monitor for reduced statin effectiveness, and that's carbamazepine, oxycarbazepine, phenytoin, rifampin, rifabutin, rifapentine, and St. John's wort. Here is a list of drugs that could interact with all statins. So gemfibrozil should not be combined with statins. Fenofibrate can be used with low or moderate intensity statins if the benefits are judged to outweigh the risks of adverse events. Then the bottom half of the slide shows statins that may increase the anticoagulant effect of warfarin. So consider instead using atorvastatin or carefully monitor the INR and for symptoms of bleeding.
Review these guidelines for statin therapy monitoring. Only check the ALT at baseline and repeat if symptoms of hepatotoxicity occur. These symptoms may include unusual fatigue or weakness, loss of appetite, abdominal pain, dark-colored urine, or jaundice. The third one states to check creatinine kinase at baseline in patients at increased risk for myopathy. Note number 5, which states to check fasting lipid panel 4 to 12 weeks after statin initiation, then every 3 to 12 months. Non-statin therapy includes bile acid sequestrants, cholesterol absorption inhibitors, which is ezetimibe, fibrates, and PCSK9 inhibitors. There really is very limited use for these non-statin therapies. Avoid initiation of gemfibrozil in patients currently on a statin due to the risk for rhabdomyolysis. Generally, the non-statins are currently added in select scenarios, beginning with ezetimibe, then PCSK9 inhibitors. Bile acid sequestrants are the third choice for patients who cannot achieve the appropriate reduction with a statin. Ezetimibe add-on is a reasonable second choice, and then if the LDL threshold is still not met, then a bile acid sequestrant can be considered. Consider use of a fibrate in conjunction with a low or moderate intensity statin when triglycerides are above 500 milligrams. And the benefits of reduction of ASCVD risk or triglycerides are deemed to outweigh the risks for adverse effects. So fibrates when triglycerides are greater than 500. I don't expect you to know these situations specifically. Keep the generalizations in mind of which drugs would be considered in what order. Okay, here's some vignettes. What is optimal intensity of a statin therapy for a 63-year-old man with an ST elevated MI? Or a 26-year-old woman with elevated LDL of 260? Was noted in her teens and it has a positive family history of coronary heart disease. And a 44-year-old woman with diabetes, well-controlled hypertension, and microalbuminemia. None of these need an ASCV risk calculation. The first man has clinical ASCVD, but is less than 75 years old, so he would need a high-intensity statin for optimal risk reduction. The 26-year-old woman has an elevated LDL, but she does not have ASCVD. She does have risk factors. She belongs in the second patient subgroup, and the recommended intensity of statin treatment for her is high. If her LDL levels remain very high after the intensity of statin therapy has been achieved, addition of ezetimibe may be considered to lower the LDL further. The 44-year-old woman with diabetes does not give us enough information. She would need a moderate or high intensity statin treatment. Since she has microalbuminuria, she is at greater risk for myopathy, so she should have a moderate statin intensity treatment. So I think these are pretty good vignettes putting together some of our information. And these are more like questions you would see on the exam. Okay, here's a 56-year-old African woman with multiple ASCVD risks. We have very little information to inform us in this scenario. So we know she has multiple risk factors, so we know she is not low risk for ASCVD. The pool cohort equations can be used to estimate the 10-year ASCVD risk for African American individuals. We do not know her personal characteristics that would inform the decision regarding safe statin use. We would need to know her past medical history, her kidney and liver status, LDL cholesterol, and medications she is taking at a minimum. There should be a clinician-patient discussion before statin treatment is initiated. This is a 38-year-old Caucasian man with a strong family history, yet his LDL is not above the 190. This gentleman does not fit into any of the 4 groups that would benefit from a statin. Additional factors that increase risk may be considered. In this case, we can use the LDL greater than 160 and a family history of premature ASCVD as factors to inform the decision about statin treatment. For this man, statin therapy for primary prevention may be considered after evaluating the potential for ASCVD risk reduction benefits, adverse effects, drug-and-drug interactions, and discussion of patient preferences. This is an example of work guidelines that inform clinical judgment but do not replace it. In summary, there are several factors to consider. Lifestyle modification remains the cornerstone to therapy. Download an app and document the 10-year ASCVD risk for your patients in the patient record. Greater emphasis on these guidelines is placed on randomized controlled trials and meta-analysis. Remember the 4 major statin benefit groups. The guideline is a guideline and does not supersede clinical judgment. There's less emphasis on non-statin therapies. The new goal of hyperlipidemia treatment is to treat the level of ASCVD risk with the appropriate intensity of statin therapy. Thank you for your time and attention. Your patients depend on you.